Hello and welcome everyone. Today's presentation is on the cytomegalovirus reactivation in ICUs. Herpes and cytomegalovirus reactivation. We see frequent reactivation of herpes, especially cytomegalovirus, in bacterial sepsis. Cytomegalovirus reactivation is associated with worse clinical outcomes, that is higher mortality, longer ICU and hospital stays, and increased secondary infections. The intense and dysregulated inflammation combined with the compensatory anti-inflammatory response, these immune perturbations are speculated to facilitate what is the reactivation of the cytomegalovirus. Specific mediators and pathogenesis of this process remain undefined. So the reactivation and clinical outcomes. It is unclear if the reactivation is a marker or a cause of worse outcome. Now, evidence suggests possible causation are consistent observational findings linking this reactivation with worse outcomes. Biologically plausible mechanisms from immunosuppressed population and animal models are seen. Preliminary clinical data shows improved outcome with prophylactic antiviral treatment. Let's see what is the data that is coming in from the observational studies of the reactivation in critically ill patients. Now, in adults in critically ill patients, the study is coming from diverse ICUs dealing with various patients like sepsis, trauma, burn, major surgery, and acute myocardial infarctions. Studies varied in the patient population, the technique and the definition of the cytomegalovirus reactivation, and the analytical approaches that were done. The consistent findings were frequent cytomegalovirus reactivation, that is around 30% in critically ill, especially in the sepsis subgroup. Now, association with adverse outcomes, as we have already discussed, is established. The baseline risk factor for cytomegalovirus reactivation are not yet consistently defined, though greater severity of the illness is a quite obvious potential risk factor. Now, reactivation is likely adds an independent risk factor for worse outcome beyond this severity. Now, challenges in identifying the high-risk population, inconsistent baseline predictive factor, complicating activation of the patients, identification of the patients with CMV prevention studies, novel approaches like CMV-specific immunity assessment needs to target high-risk population for future trials. Now, the cohort study findings show that cytomegalovirus reactivation consistently is associated with worse outcomes, and this is across the studies. Limitations of this study is that it is very small population and very specific subgroups like burn, trauma, AMI, and they lack quantitative CMV detection. And the endpoints, what happens after we have detected, they are non-blinded endpoints, so we are not very sure about the bias that has been introduced, and most of the statistical analysis is incomplete, especially because of the small sample size. So what are the potential biologically plausible mechanisms to suggest why the CMV is associated with worse clinical outcomes? The general hypothesis is that critical illness such as bacterial sepsis facilitates the reactivation. CMV reactivation may independently worsen the clinical course through multiple mechanisms. The hypothesized mechanisms are direct or indirect lung injury. CMV reactivation can cause or exacerbate a lung injury. Observational studies show that CMV reactivation is linked to worse lung-related outcomes, that is longer mechanical ventilation. Lungs are the major site for CMV latency and reactivation. Animal models, that is mouse sepsis models, show that CMV reactivation leads to lung injury and elevated inflammatory markers. Amplification of the inflammation. CMV can amplify the systemic cytokine response, including the IL-6, 8, TNF-alpha, and IL-10. Elevated cytokines are associated with increased mortality in critically ill. Antiviral prophylaxis in trials did not reduce the cytokine response systemically despite suppressing the CMV, suggesting that local lung inflammation may be more relevant. The secondary immune suppression, CMV can induce immune modulation mechanism by IL-6 expression and altered T cell subsets. This can result in increased risk of secondary nosocomial infections like VAP, bacteremia, and fungal infections. It is supported by studies in solid organ and hematological hematopoietic cell transplant patients. The supporting evidence in RCTs is that antiviral drugs reducing CMV reactivation improve the overall survival in hematopoietic stem cell transplant patients. Now, CMV associated lung injury observed in various studies and animal models. Ganciclovir treatment in the mouse prevented CMV reactivation and also prevented lung injury. Observational data shows that association with CMV reactivation with longer mechanical ventilation and higher infection rates, increased inflammatory markers in CMV positive mice during sepsis. So this is a flowchart which shows these sepsis-associated respiratory failure, which results in immune dysregulation and various unknown factors as of now, in which can terminate this by ganciclovir, but this is a theory as of now. We are not sure whether this intervention is going to save lives. So this immune dysregulation results in CMV reactivation. The CMV reactivation has two impacts. The direct impact is on the lungs, where it causes injury and inflammation, and the indirect impact, where the immune activation and immune suppression because of the CMV results in organ failure and nosocomial infections. Secondary morbidity and mortality associated with CMV reactivation are prolonged mechanical ventilation, hospital and ICU stay, as well as increased mortality.